I want to take some time now and zoom in on the artery. You mentioned the capillaries, but I want to talk about plaque and the whole cascade that leads to plaque and connecting that to this metabolic dysfunction.
Thanks. That's one of the things that I didn't realize until I started talking with a lot more people in the low carb community. There's just not a lot of people that have focused that much on plaque. That's one of those places where common knowledge just doesn't work. And metabolic disease can be a complicated place where quite often common knowledge is not so common and maybe it doesn't work. So here's what I'm talking about with this specific issue with plaque. Most of us have an idea. Number one, that plaque lines the inside of the artery wall, and it just keeps lining it until it closes it off. Sounds reasonable, right? But that's not what happens. Plaque actually forms between the inner lining, what we call the intima, and the media layer, the muscle layer, the middle lining of the artery wall. Why is that important? Well, just hang in with me just a second more. It's not that squeezes the artery off slowly. And think about it. If that's the way it worked, we should be able to predict when somebody's going to have a heart attack because you can watch that artery slowly squeeze off. That's not what happens. And the reason that we can't predict it is because it's not what happens. What we're looking for is soft plaque. Our body knows that LDL, that plaque, should not be in that area, that lining area of the artery wall. So our body will say, look, let's attack this. Let's send the immune cells in. Let's start releasing enzymes, and let's just digest it. So far, so good. Because it is digesting it, it makes it soft. It's sort of like mucus, sort of a soft mucousy type of consistency. Here's where the problem starts, and here's why we really can't predict a heart attack or a stroke. Because it's not slowly closing it off. It's when you have that inflamed plaque and it bursts through. When that mucus bursts through and touches the flowing blood, it forms a clot. And if the clot's big enough and it goes to the heart, that's a heart attack. If it's big enough and it goes to the brain, that's a stroke. If it's multiple microscopic levels, you can get a heart tissue that looks microscopically like Swiss cheese and one of the forms of heart failure. Same thing with the brain and some dementia problems. So again, understanding the organic or metabolic microscopic details of what plaque is gives you a whole different perspective on what to do next, how to evaluate risk for heart disease and stroke, and what to do about it.
So when it comes to this soft plaque, the rupture, the formation of a blood clot that can then lead to a heart attack or stroke, what is it that sets off that cascade? What I'm getting at here is what's the difference between somebody that has soft plaque that's sitting there, say, for years and they're okay versus that person that has whatever it is, which is what we're getting at here, that puts them over the edge and dislodges that, sending the plaque into the blood flow to start that whole cascade?
That's a really good question, but there's a piece of it that I want to touch on. You're not going to have soft plaque sitting there for years. What makes it soft is a process called inflammation, your own immune system attacking that plaque. That's a process that goes on weeks, maybe months, but it's not going to go on for years. What's going to happen is the body's going to say, hey, we have cleaned this up, and then it forms scar tissue. Scar tissue, just very stable. And you'll actually notice it from imaging results that show calcification. So once we begin to see calcification in that plaque, we know that it's stabilizing. There was a researcher that did this once. His name was Honda. I think he's in Washington State, but I'm not sure. And what he did was he took hundreds of images of people and their arterial plaque. One thing that he showed was calcification is not a subjective thing. It's very objective. He actually used optical character recognition to see how much calcification was in plaques. He split these groups into two groups. One group did not have any calcification. The other group did. The other group, the study group, the calcification group, had a couple of events right in the very beginning as they were adjusting, and then they never had any more events. On the other hand, the group that did not have calcification of that arterial plaque just kept having event after event after event after event. And by event, I'm meaning heart attack and stroke.
So I guess the better question then, what's the difference between a plaque that calcifies versus one that ruptures? What are the factors at play there?
Really good point. I think what you're getting at is, I get into this geeky stuff with patients and they'll sit and listen very politely. And then they'll say, well, great, but what does that mean for me? What do I do? So again, if you begin to realize that what we're talking about is active inflammation, the real question I think you're getting at is what causes inflammation? And I'm assuming that's correct, right?
Well, that could be underlying it, but I'm trying to decipher what it is between the quote unquote lucky people that calcify versus the person that has the rupture and then the event that follows.
Well, the big three things that do cause risk for this, and some of it is luck. One of them is genetics. And yes, genetics tends to be luck. But the other two, not so much. Well, one of them's not. It's lifestyle. And then the third is age. Now, we would love to think that there is no reason to age. That's not entirely true. Aging is going to have an impact on us, even if we manage our metabolic health. But let's go to that third group. The one of these three things that you can control is your lifestyle. And here's what we know. For example, a blood sugar that's going up over 140, or I think 7.8 if you're outside of the US, if it goes up over 140 and it stays there hour after hour after hour, that irritates, inflames the lining of your artery walls. We also know that people that have high levels of insulin, but not quite so much high levels of glucose, and that's what you see with early prediabetes and early diabetes. We can talk about that later if you want. But high levels of glucose or even high levels of insulin, and clearly high levels of both, irritate that lining of the artery wall. I just happened to see your interview with, I'm blanking on, is it Ketke?
Oh, Gary Fettke.
Gary Fettke. He started talking about the glycocalyx. So I mentioned the lining of the artery wall and the intima. That intima is a one-cell layer thick lining. What Gary's talking about in his interview with you recently is some little hair-like structures that come out of that intima lining. Those hair-like structures just get mowed over by high levels of glucose or high levels of insulin. When that happens, those hair-like structures protect the intima, and they're no longer there to protect the enema. What has been demonstrated by some researchers at, I think it's UC Southwest in Texas, a thing called transcytosis. And pardon the geek words. All it means is trans means going through, and cytosis means going through the cell. So what we know now is if you injure that glycocalyx that Gary was talking about, and he was right, it really is the largest organ of the body, not the skin. And it's one of the most important because, as you'll see as we go through this conversation, that's what leads to, as you know already, the vast majority of heart attack, stroke, dementia, blindness, kidney disease, heart failure, even for men, erectile dysfunction. So this organ, the glycocalyx, is so important. And it gets back to the question that you've been asking me, trying to get me to focus on. What causes that continued inflammation? Does that help? Or did I still leave it confused?
So the way I'm understanding what you just explained there, elevated blood glucose, elevated insulin, those causing damage to the glycocalyx, and then eventually leading to inflammation is part of this too. And I want you to clarify exactly how that fits in. And then eventually this leads to the plaque formation, like we were talking about. I'll have you jump in and clarify if I have any holes in that.
Okay, a couple of points. We've mentioned a couple of names already. Ben Bickman, I'll also mention. I'm a big fan of Ben's as well, and he does a good job of dealing with hypertension, high blood pressure. There are a couple of reasons that having high levels of glucose, high levels of insulin, and even what we call AGEs, advanced glycation end products, and again, a whole bunch of technical terms, but AGEs, the advanced glycation end products, is really, we've all heard of the most common one, hemoglobin A1C. It's where glucose binds to a protein, in this case, hemoglobin. All those things tend to impact the kidney, and the kidney makes our blood pressure go up. The reason I brought that up is, a lot of people would say high blood pressure causes this. I think if you talk to some of us, we would say, yeah, high blood pressure is a big deal, but it's actually more of a result of this process than anything else. This irritation of the lining of the artery walls because of glucose intolerance, insulin resistance, prediabetes, metabolic disease, whatever you want to call it. Back to your point about what causes that, the on button or the off button, what causes it to increase? Again, if you have damage to that glycocalyx, that's going to increase this inflammatory process because you're going to continue to get that transcytosis, the LDL fading through that intima lining, fading through the glycocalyx, fading through the intima lining, and getting stuck between the intima and the media. As long as that process is continuing to happen, your immune system is going to be continuing to attack this process to try to pull that back out by liquefying that LDL or that plaque. Liquefied plaque is what gets us. So in a way, at the end of the day, when you think through all this, we're really taking friendly fire. And the goal is to start slowing that process down. How do you slow it down? Slow down the injury rate from the very beginning. And that gets you back to the low-carb community. A lot of folks would just say, forget all that science. Just don't eat carbs. And I get it.
One thing I want to make sure we clarify is the chronic nature of this versus acute. Because even somebody like you or me, I'm sure even being aware of the importance of keeping things generally low carb, we might go to a birthday party or have a celebratory meal and have that quote unquote spike in blood glucose. How does that differ in the case of somebody like me or you doing that just periodically versus somebody doing it day in, day out? Because I'm assuming you're going to have the damage to the glycocalyx, the inflammation like we've been talking about.
Mm-hmm.
But because it's so infrequent, does it just allow the body to calcify that and repair that?
Well, first of all, I'm glad you brought it up that way, and I get banged on that a lot. I'm a Southern boy, born in South Carolina, the land of, once a year we'd go out and pick blackberries, and we'd make it in a cobbler, which basically just pours the sugar, the glucose into it, or sucrose, in addition to the fructose from the blackberries, and then you put a grain crust on top of that, and then you put ice cream on top of that. And then you have that with maybe 2 glasses of really sweet iced tea. Now, I don't do that anymore, but that's the culture I grew up in. You're Canadian, right?
Yeah, from Ontario.
So I'm sure you have some of that kind of stuff in your culture too.
For sure.
And I'm also happy to hear that you sound a little bit more like me. I think like an engineer. So a lot of the people that come to see me as patients think like engineers, and some engineers can be a little bit rigid and get very surprised that I'll go ahead and have dessert sometime. My family has a dinner event every Monday night, and my sister is a great Southern cook. And sometimes when she fixes something like, and down here we fix food, we don't make it. Sometimes when she fixes something like a coconut pie, I'll just have to get a bite. I've gone home. I've had episodes where I've had my CGM on, my continuous glucose monitor. And pardon the story, by the way, I am getting to a point. I remember episodes where my blood sugar has actually gone up over 200. That, by the way, is one of the criteria for full diabetes. So yes, I'm full diabetic. But let me finish with the story. I'm getting somewhere that responds to your question. So I've got what some people might call an assault bike. The bikes that they're wind driven. Back in my day, and I've got one that's like 30 years old, and back in that day, they called them Schwinn Airdynes. It's an old rusty Schwinn Airdyne at home. So I'll have a blood sugar of 200, go sit on the Schwinn Airdyne, and within 5 minutes, I'll have that blood sugar back down to 105. Has happened more than once. Now, the reason I'm bringing that up is to get to the punchline. And the punchline here is this. From looking at my own CIMT, from other imaging studies, from looking at my own metabolic information, it's really clear that I continue to stabilize plaque. I continue to stabilize and improve my metabolism. So no, you don't have to be rigid. You don't have to say, I'm never going to eat any carbs at all whatsoever. Now, I do tend to stay, I use a breath ketometer, ketone meter, and I do tend to stay mildly ketotic about 4 to 5 days a week. But, that doesn't mean that I don't take a carb vacation every now and then. We have patients. Part of what we do when we see patients is we get them started on a CGM, continuous glucose meter, fairly quickly. And we'll typically learn two or three things. One of them is, oh my gosh, I had no idea so many things spiked my blood sugar. Another thing that patients will learn on the other side is, oh my gosh, my son had a birthday. I went out for pizza and beer with him because that's what he wanted. I just took an easy walk about 20 minutes later, and it took the top right off of the spike, that blood sugar spike that I expected to have and that I knew that I'd have. It's not that difficult.
When you're on one of these carb vacation days, one of, say, 3 days during the week, is that strictly for social and for taste of these foods? Or do you feel like there's a health benefit going in and out of ketosis?
That's a really good question. I've looked at it a couple of times, and I've decided I'm not so sure. I don't know one way or another, but I don't think it hurts you. I'll also say that it's not, I don't take carb vacations 3 days a week. Usually it's one, sometimes two. And it may take me a day or two to get back into ketosis. Quite often it doesn't because my big workout is on Saturday and Sunday.
Coming back to the vasculature and the damage there, the inflammation, somebody having a carb holiday once a week like yourself, do you feel like you're causing damage to vessels doing that periodically? Or does it take a constant insult over a period of time, chronically, before damage is done?
Well, a couple of caveats we need to think about. One is that we're all very unique. And so, for example, I don't know what your numbers are. I do know that I have some people come in to me that have little or no response on a glucose challenge. On the other hand, if I take a glucose challenge, my sugar will go over 200. So each of us is different. But as I mentioned before, we're watching my plaque on a regular basis, and we're putting the results right there on our channel, and it's improving. It's not getting worse.
I guess what I really want to make sure we clarify, though, do you feel like you're causing damage and then calcifying and then moving on? Or do you feel like because you're metabolically healthy, having the insult so infrequently that it never gets to that point of damage?
That's a really good point. So to put this in a different way, I think it takes more than half an hour or an hour once a week of high blood sugars to do this damage on a regular basis. So, and let's go back and look at it. I've got a mild level. I do hit full diabetes when we challenge, but it's still a very mild level. I'll hit to 210, 220. We've got people that'll hit up to 350 with a normal glucose challenge. And think about this. And I get that challenge, that hit, when I just do, like, again, a half a piece of my sister's coconut pie. Think about this. I don't eat bread when sometimes I have eaten at McDonald's. I will continue to do so. I'll get like meat, no bread, no Coke, none of the carbs in a routine meal there. But let's say that even at my level, very mild diabetes, I had a 64-inch Coke, regular Coke, not diet, French fries or milkshake, all of these carb sources. And let's say I did something similar, like maybe spaghetti for dinner. And then let's go back and assume maybe my blood sugar actually hits 350. This kind of person with this kind of diet, and let's say they started with oatmeal in the morning thinking they were healthy, or Cheerios Honey Nut, or Honey Nut Cheerios, their blood sugar is going to be 250, 300, maxing out 8, 10, 20 hours per day, every day. That's just so different from an occasional once a week 15 to 20 minute increase up to 160, 180, 200, and then back down. Totally different universe. There's a book called Blood Sugar 101. Jenny Rule. Have you heard of it? Or have you seen her website?
No, I haven't.
It's a good one. I haven't seen it in a couple of years, but when I was looking at this specific question, what level of blood sugar for what amount of time causes this irritation to where you start forming plaque or cardiovascular risk? She's not a medical scientist, but she does pretty good. And she had looked at that data a few years ago, the evidence, and she made a good case that you need to be over 140, and you need to be there hour after hour after hour. And obviously the higher over 140, like 350 for 20 hours a day, day after day, that's dangerous.
If you enjoyed that clip, you're going to want to head over here and catch the full episode. I'll see you over there.
I started as an ER doc. I love doing emergency work, but most of these things coming into the ER should have never happened. High levels of glucose or even high levels of insulin irritate that line.